Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Today we're doing something that we've been doing maybe every quarter that we now call Hollander Rounds. It's named after Harry Hollander, who's in the audience, who was residency director here for a generation, a spectacularly terrific physician and educator who really special sauce was his excellence in diagnostic reasoning. And so a couple of years ago, we renamed these clinical problem-solving cases Hollander Rounds to honor Harry's legacy. And so today we are doing another one. These are clinical problem-solving cases. Our discussant is Rachel Bystrzycki, who is associate professor here in the Department of Medicine in the Division of Infectious Diseases based at UCSF Health. Rachel received her MD from Mount Sinai, did a residency in medicine at Columbia. She was chief resident there. And then we lured her to this coast where she did her ID fellowship and joined the faculty. And she is a superb clinician educator whose clinical activities include seeing outpatients in the ID clinic, doing inpatient consults at several of our sites. She also serves as the medical director of the UCSF Outpatient Parenteral Antimicrobial Therapy Program. And we'll have another speaker later to talk about what we learned from the case. But let's go ahead and get started. And here are the ground rules. As people who've been at these before know, our discussant is blinded to the case, does not know what case is being presented. I think is guessing it might be an ID case, and there's a pretty strong ID audience, but you never do know. Our goal is to learn from the thought process of a master clinician rather than getting the case right. It's sort of nice when they do get the case right, but that's not really the goal. The goal is to see how they think about the case and how they do clinical reasoning. And also, I think to demonstrate it's not crucial that you know everything. You can look some things up, but the reasoning process is really what this is about. And we will encourage audience engagement if the time comes, and you are, Rachel, happy to have you call on the audience if you'd like. So these really are some of the more fun grand rounds that we do. We're looking forward to it. As we get started, any comments before we gear up?
No.
Okay.
Let's get into it.
All right, let's do it. All right, make sure you're holding the mic close to your mouth when you speak, and let us go. History of present illness. A 68-year-old woman with a history of type 2 diabetes presents with 4 weeks of headache and intermittent tactile fevers. And normally we kind of go on and give you more details, but this is a pretty meaty chief complaint. So why don't we stop there and ask how you approach patients with headaches and fever, and then we'll maybe get to some of the specifics of some of the elements of this patient's phenotype.
All right. Well, so 68-year-old woman with a subacute presentation with headache and intermittent fevers. So the first thing I'll think about is infection. As an infectious disease specialist, and I'll think specifically about CNS infections. So 4 weeks is, not a super acute presentation. So I'll think a little bit less about acute bacterial meningitis, but I'll be thinking about chronic meningitis or other CNS infections like brain abscess. And then it's also possible that the headaches are not actually from a CNS infection, but rather a symptom of a more systemic process.
Okay, and so what does the 4 weeks rule out in terms of CNS infections?
So I think like pneumococcal meningitis, Neisseria meningitis would be very unlikely. Like acute viral meningoencephalitis would be unlikely, but chronic subacute meningitis like CNS cocci, TB meningitis, brain abscess.
Mm-hmm. But viral meningitis, this would be unlikely that it would go on this plain old, this kind of viral meningitis you sometimes see in the ER. 4 weeks would be long?
Correct, yes.
Okay. Diabetes put her any special risk for anything other than, we assume, sort of mild degree of immunosuppression from diabetes, but any things that you worry particularly when you see diabetes on the list?
Yeah, so if she's presenting with severe hyperglycemia, another thing I might think about is invasive fungal sinusitis, which can present with headaches. 4 weeks is a bit long from that, but sometimes we see more of a subacute presentation occasionally.
Okay, Good. Let's go ahead and see a little bit more. So a little bit more about the headaches. They're left-sided episodic, have increased in severity since they began. Has also had a dry cough and pleuritic chest pain. Denies eye pain, vision changes, neck stiffness, numbness, or tingling. Her daughter had noticed that the patient had been tired, appearing, and mildly confused. So have you riff on that? I'm happy to go back to it if you'd like.
So now we've added in an additional element of respiratory symptoms with cough and pleuritic chest pain. So now I'm starting to think about, could this potentially be like a lung-brain process? With the pleuritic chest pain, that suggests there may be like a focal lesion in the lung that's causing these symptoms, like consolidation or a pleural effusion. And so do you want me to expand upon different?
Yeah, well, first of all, in the ID world, is that a thing?
Yes.
It's like there's like a chapter in an ID book on lung brain things.
Yeah. So when we start thinking about lung brain things, then there's a certain differential that we think about of infections that can start in the lungs and then disseminate to the brain. So examples would be tuberculosis, fungal infections like Cryptococcus, cocci, typical bacterial infections, like if you have a lung abscess that then with like staph that hematogenously spreads to the brain, and then nocardia would be another one.
And as you pair your lung brain list with the 4 weeks, does that change it at all, or all the things you named can be protracted that way?
Yeah, I think all of the things could be protracted. Staph aureus or typical bacterial processes usually would present in a shorter period of time, but occasionally we see a more subacute presentation, common things being common.
Mm-hmm. And I assume you're operating in Occam's razorville here, that this is one thing.
Yes. The other thing to think about would be, could she have, infectious pneumonia and the headache is just a symptom associated with that. So with viral pneumonia, any kind of pneumonia, you could have headaches as part of that. Also with cocci pneumonia, headaches are pretty common. You haven't told me anything about her social history, but I'd want to know about.
And cocci pneumonia, you say headaches are common, but not necessarily because CNS involvement?
So you can have both. You can have cocci meningitis, but also it's fairly common to have headaches.
Any idea why when it's not involving the CNS?
I'm not sure what the pathophysiology is.
Any of our ID folks know anything about that? No? We got a lot of no's. Okay. Good. And I guess whenever I hear two things, might they be related? And I also wonder, it's possible she's taking something for thing one that's causing thing two, that, to try to link them rather than being one syndrome.
Yeah. So you can have aseptic meningitis related to medication use.
So on the list of things you'd wonder about, is she taking something for the chest pain that may be inflaming her CNS? Okay, so an interesting thought. But your bias at this point is to try to package this as a single entity that I guess the pathophysiology is of all the lung brain things, is that the typical thing? They begin in the lungs and then spread to the brain?
Yeah. And the thing that's also pointing me towards it being truly a combined syndrome is that, cough is common, but pleuritic chest pain is a little bit less of a common non-specific symptom. But
okay, great. Let's see a little bit more. So we'll get you some more past history. Type 2 diabetes with a high A1C, had a benign breast cyst that was resected, just on metformin, no tobacco, alcohol, or drug use. Recently moved to San Francisco from Michoacan, Mexico. I do not know where that is, to live with her daughter. Lives in Arroyo Grande in the Central California coast. Before we get to the physical, anything stand out to you here?
Yeah, so she's from Mexico, so she has risk factor. That's a risk factor for having tuberculosis, which would certainly be on our differential based on the symptoms. And then Central California, think about cocci, a little bit less on the coast than in the valley, but you can also see, we see cases from the Central Coast also.
And we don't have the timing here of when she moved from Mexico to the States. Does that matter?
No, because TB is often a reactivation illness. So even if she had immigrated as a child, it would still be a consideration. And we see tuberculosis also as well.
Any things where it would matter that, if she had come to the US from Mexico 5 years ago, it couldn't be some other pathogen?
Yeah, I'm trying to think about pathogens that would come specifically from Mexico. Not really. I mean, parasitic illnesses can also have a long latency period, so it seems a little bit less likely with this clinical presentation.
Okay, good. And if any of our ID colleagues here, or anybody else wants to add anything, let us know. Okay, we have some physical exam. She's afebrile right now, not tachy, blood pressure 109/68, respiratory rate 16, well saturated in room air, so all fine. Tired appearing, HENT is fine. Eyes look okay, neck is supple, cardiac exam is normal, nobody hears a murmur or a friction rub. Pulmonary exam appears to be breathing comfortably. She's got a cough, but appears clear, no rub there either, or crackles. Abdomen is benign, no extremity edema, and a lot of red on the neuro exam. Alert oriented times 2, but not to city. Hypophonic voice, mild word finding difficulties, impaired naming of objects, counting 1 to 10 intact, repetition with errors, arm strength 4+/5, right arm strength 4+/5, left 4 out of 5, and some finger to nose finger dysmetria. That sounds like an exam done by a neurologist. Normal gait. All right, so take us through the physical and how it shapes your thinking about her.
So I think the most notable thing here is the neuro exam. She's not oriented to place. Now that's non-specific. She could have delirium, but the fact that she has some focal neurological deficits is making me think that she actually does have a focal CNS process. So she has decreased strength. I guess it's on both sides. Right-sided dysmetria. And some cognitive impairment. So this is making me think more that yes, there is a CNS process going on. It's not just non-specific headaches related to a systemic illness.
And in terms of the CNS process, does it make you think that there's a space occupying thing as opposed to general meningitis or general encephalitis?
Yeah, what we're not seeing is nuchal rigidity, which is not so sensitive for chronic meningitis, but the focal deficits make me think that there's a focal lesion.
And does that, I guess, I'm sure we'll get to imaging at some point, but does that change your thinking about the list of stuff that could be in the brain? Some of them are space occupying, some of them are more generally distributed?
Not really, because all of them can cause space occupying lesions, TB, nocardia, cocci, cryptococcus. I mean, some are more likely to cause a meningitis rather than a space occupying lesion like cocci, and crypto are more often meningitis than a focal lesion, but they can cause focal lesions as well.
Okay. You haven't mentioned echinococcus that you seems to come up in every case of someone who's been in Mexico and has something going on. Is there a reason for that?
Yeah, so echinococcus can cause pulmonary disease and also can cause CNS disease, but CNS disease is really rare. And I also wouldn't expect kind of a 4-week presentation with fevers.
What do you expect?
Probably all the cases of pulmonary echinococcus I've seen have presented more indolently and then with like hemoptysis. I've never seen a case of CNS, but I would expect it to be more indolent and probably not presenting with concurrent symptoms at the same time.
Interesting. Okay. Right. So, yeah, any comments on that? Everybody's agreeing? Harry, go ahead. Actually, let me get you a second. A little bit easier. All right, so this is the Harry Hollander of Harry Hollander Rounds fame.
What I'm struck by not finding on the abnormal neurologic exam is cranial nerve findings. I mean, to the extent that many of the things that you've mentioned, Rachel, cause a predominantly basilar meningitis, those rather than cortical or cerebellar findings, at least early on, are I think more common in many of the chronic meningitis. This sort of has a flavor of diffuse cortical and maybe cerebellar involvement.
And Harry, is that hypophonic voice? So you're not saying that that could be a cranial nerve involvement, more hoarseness, hypophonic? I don't know. That's throwing that out there.
Any comments, Rachel? Nope. Here we go.
Yeah, I mean, I think it's still, it's hard for me to say. I can't say I'm very good at localizing lesions based on
But
neuro
I guess the
exams.
general teaching point is a lot of the chronic meningitis seem to glom onto the brainstem, and typically often there's some cranial nerve finding.
Yeah, but I don't think that's a sensitive.
It's not, so it, not seeing it doesn't really change your thinking about what might be going on. So it's
Yeah.
interesting.
Yeah.
Okay. Any other comments or thoughts? All right. Where do we go?
I would say the next step would probably be imaging both of the brain and the lungs.
Mhm. Okay, and you lobby for any particular kind of imaging here?
I would do an MRI of the brain and then a CT of the chest.
Okay. They got some basic labs first, and you see here mildly elevated white count, mildly low sodium, glucose as expected elevated, mild elevation in alk phos, everything else is fine, albumin's okay, CRP 13.6, and urine benign except for glucose. Any comments on any of this?
Pretty non-specific, mildly elevated white blood cell count, but nothing dramatic. Maybe making me think that a typical bacterial infection is less likely, but certainly doesn't rule it out. Mildly elevated CRP also, very non-specific, not as high as I would expect to see with the staphylococcal infection.
And the staph infection, as you were wondering about brain, lung things, is a staph pneumonia and then embolic?
Yeah.
Staph traveling
Embolic
to the
or
brain?
hematogenous.
Okay.
Just
And speaking of embolic, is when you see problems in two different organs, is endocarditis on your list here in any form?
yeah, so it certainly would be like, that's a good point. Subacute bacterial endocarditis would also be a consideration with CNS septic emboli.
And does the fact that would then mean part of it's in the lungs and part of it's in the brain and sort of different sides of the heart, does that change your thinking about endocarditis as the probability?
You can have multiple valves involved. So the pulmonary emboli would come from the right side of the heart, but the brain would be from the left.
Okay.
But you would also, in a high-grade bacteremia, have just hematogenous seeding of the brain as well. But it's that feels less likely.
Because of it's just less likely disorder, or the timing's not right, or what about that's not a good fit here?
The timing, although, with actually, I think actually on further consideration, I think it's a reasonable.
Okay, so I mean, in some ways, thinking about the possibility of endocarditis when you see some infectious syndrome that's hitting multiple places, but in this case, you've got to say it would have to be on right and left side, or there's an intracardiac shunt, or something to explain hitting both lung and CNS. But otherwise, it could fit this syndrome.
Septic pulmonary emboli to the lung could certainly cause pleuritic chest pain because they're often peripheral lesions.
Okay. Here is your MRI of the brain, and we'll get a formal reading, but anything, you want to make any quick comments about it? That doesn't seem right?
That seems abnormal.
That seems abnormal, right? There's a ventricle somewhere, but that's not what it looks like. Okay, so let us, helpfully, there you go. And so this is the formal reading, multiple peripherally enhancing masses in the supratentorial and infratentorial brain with central reduced diffusion in the larger masses in the left temporal lobe and right cerebellum. So that's interesting. So
Yeah.
does that change your thinking at all in terms of what this could be?
So this suggests that there's some kind of hematogenous process because there are multiple lesions and they're widely distributed. So in terms of the differential we already formed, bacterial processes, staph or strep. We mentioned tuberculosis. It's still possible, but that lesion seems kind of big to
Mhm.
me. Tuberculosis, I haven't seen a lot of TB that looks quite like this. The tuberculomas tend to be a little bit smaller, and we're not calling meningitis also concurrently, but that's not really an MRI diagnosis. Nocardia would definitely be a consideration with multiple lesions. And then cocci, can you go back to the read? How many lesions were there?
Multiple.
Multiple, yeah. I mean, could still be.
How does the number affect your thinking about cocci?
I just don't think of it as causing like numerous lesions, but I'm not sure how numerous these are.
And all of these things, the TB, the cocci, the nocardia, I'm trying to remember all the ones you said, all start in lung and then spread hematogenously to the brain? Is that?
Yeah. Mm-hmm.
And when they do that, do they go kind of exclusive to the brain, or they just go into the systemic circulation? You can get lesions in other parts of your body.
You can get lesions in other parts of your body. Certainly, like cocci can go anywhere, TB can go anywhere. Nocardia, in theory, I can go to other places, but that's not very common. Often it's truly a lung brain process.
Interesting. And in terms of the endocarditis hypothesis, what bugs would this be? And is that CNS appearance typical of what would be a bacterial spread to the brain?
I would have to ask the radiologist, but the centrally reduced diffusion does kind of suggest a pyogenic process that one could see. But, it's interesting in the read, they're calling them masses and not abscesses. So, I wonder if there's like an atypical appearance that they're getting at.
So you'd expect if it was endocarditis, it would appear like an abscess with the usual sort of enhancing kind of thing.
The other thing we haven't mentioned is like, it's also worth thinking about non-infectious processes like malignancy. So you could have like a lung primary and brain mets, or
with some central necrosis, like, yeah, we wouldn't do that to you. We wouldn't present a
I don't think
non-ID case to you, but I think it's really important to raise that possibility. There are probably even other non-malignancy, non-ID sort of collagen vascular rheumatologic kinds of things that could do it, although none of them are cross my mind. Anybody, are there other things on the list that people are thinking about? Nothing? All right.
sarcoid maybe, lungs, brain.
I don't know. Anybody know sarcoid, lung, brain lesions like this? I don't think sarcoid, does it cause space occupying lesions in the brain? It's not my recollection. Thought it was more of an aseptic meningitis. All right, let's see where we go. CT chest, so you suggested we get an MR headed and CT chest, and that is what they did. Diffuse clustered central lobular nodules with right lower lobe consolidation, likely reflecting infection or aspiration in the acute setting. Additional, more discrete perilymphatic nodules in symmetrical calcified and non-calcified mediastinal hilar lymph nodes, suggestive of an underlying granulomatous process. Okay, so how does that on your thinking?
Well, the first part isn't very specific. Diffuse clustered central lobular nodules with right lower lobe consolidation. I feel like half our ID consults have this CT read. But the discrete perilymphatic nodules and symmetric calcified and non-calcified mediastinal lymph nodes suggest more of a atypical process, and they're specifically getting at granulomatous. Suggest something that's spreading along the lymphatics. So a typical bacterial process would be less likely to cause this appearance. So now I'm thinking more along the fungal nocardia TB part of the differential. Okay.
And I think probably that piece also sounds a little sarcoidish, but we're down to what does sarcoid do in the CNS. Michelle, you're on GPT. You're one of the AI.
Maggie Jones, we're having a nice little thread about what we think.
Oh, what we think. All right. If somebody can look up sarcoid in the CNS, though, and whether it ever causes an appearance like that, that would be helpful. Because I think the other parts of it might be not that incompatible with sarcoid, but I don't know about the CNS. Okay, so less likely bacterial, more likely TB fungal, nocardia. What nocardia, where does it fit into the TB fungal? What is it?
So nocardia is a bacteria that lives in the environment and can cause pulmonary infections, usually in either immunocompromised hosts or people with structural lung disease, that can cause usually more of an indolent pneumonia. Although I think in immunocompromised patients, it can be more acute, and can cause, especially in immunocompromised patients, it's not uncommon to have CNS involvement.
Okay. And so you think you need to invoke some immunocompromised, whereas TB and the fungal infections, do you as well, or not so much?
You do not as much for TB and fungal. Aspergillus would be one that in an immunocompromised patient, but usually it's a known type of immunocompromised, like an immunosuppressed patient. Nocardia, there are some more occult types of immunodeficiency that sometimes are only uncovered when you make a diagnosis like this. So this patient's diabetes should not be a risk factor for this, but it's still possible that this patient has some unrecognized immunodeficiency.
It's interesting that with a normal white count, it would be some other mechanism.
Like I think like anti-GM CSF is a big one.
What does that mean?
Anti-granulocyte macrophage colony stimulating factor autoantibodies.
And that would not lower your white count? It just makes your white cells not work well?
Yeah.
Okay.
I think so.
Never heard of that.
I would have.
Okay. Let's do some exposure history. So we got a little bit already. Spent her entire life in Mexico, a warm, dry climate, and no recent travel. Spent most of her life in rural areas on a ranch. Now lives in Arroyo Grande with her children. She likes to garden, of course. Interacts with dogs, ducks, chickens, and infrequent contact with their feces. Not to get too graphic here. No prior hospitalizations, no known TB exposures, no history of incarceration, and not sexually active. All right, maybe any of that helpful to you or broaden your differential? And then what would you do next?
We already talked about spending her life in Mexico being a risk factor for TB. No known TB exposures does not really lower that for me, although if she had known TB exposure, that would bring it up on the list. Dog, duck, chicken with feces.
It's like a mental status test. Dog, duck, chicken. Yeah.
I don't know what the threshold is for frequent. Trying to think if anything, and nothing is coming to mind specifically with exposure, except that dogs at Echinococcus would be potentially a risk, but that wouldn't have this. You would expect to see like cystic lesions in the so I don't think that's very likely. Gardening, that actually is a risk factor for nocardia exposure as it lives in the soil.
Okay. Anything else? I remember rose thorns and other things that you can get from gardens.
Sporothrix. So sporothrix also can cause brain lesions as well. It's not very common, but
and lung as well.
It can, yeah.
Okay, interesting. All right, where would you go next? The ID Gropogram?
Yes, we'll order 8 million tests. So I think I would start looking for cultures of the areas that we think are infected. So lung will be easier. So I'd get sputa for tuberculosis. I also get fungal and fungal cultures, bacterial cultures to start. I would send serologies for cocci and histo. And then I would also, it looks like a pretty large lesion in the brain. So I think it'd probably be worth talking to neurosurgery if that could be sampled.
Would you be thinking about doing LP or the yield wouldn't be very good? Or how do you approach a brain lesion and also making sure it's not dangerous to do an LP?
Yeah, well, an LP seems like it would be less likely to be high yield because the patient doesn't really have nuchal rigidity and we're not seeing anything on the MRI. Probably you're actually going for the brain would be higher yield. If we can't get a brain biopsy and it's felt to be safe to do an LP, then I would get an LP.
Mhm.
Um,
And is this, often the issue comes up in the staging of this workup, I think, because some of the tests take a while to come back. Is there kind of a first step? I don't know, do you go to the brain biopsy right away here, or you'd be doing these initial serological tests and sputum tests, and then maybe having to wait a few days while this thing is percolating in the brain? How would you be thinking about the timing?
I think one of the issues is that it takes time for our test to come back, and she has a pretty large CNS lesion. So we'll usually talk to neurosurgery at least early on, and it kind of depends on the location of the lesion, how high risk it's going to be to biopsy.
Mhm.
If it's going to be high risk biopsy or neurosurgery feels like they don't want to do it yet, then we can wait for our other testing to come back. Another thing we could consider sending, which we've been doing more and more of, is blood MNGS, which we're now doing in-house, and we can
What that stand for?
blood metagenomic next generation sequencing. It's an unbiased test of blood that looks for non-human genetic material that it sequences. And the turnaround time, that is a couple of days now that we're doing it in-house.
When you say unbiased, I assume that has a different meaning than the way we think about bias, but what
You
do
don't have to, it's a bit of a fishing expedition.
you don't know what you're looking for? You're
to know what you're looking for.
testing for everything?
Yeah, basically. So not everything will show up on it, but
Mhm.
DNA, viruses, bacteria, fungi will
And are you sending that now routinely, or are you going to wait until your first salvo of your gropegram comes back negative?
I've been starting to send it earlier because it can be very helpful if it comes back quickly.
Mhm.
And depends on, how high yield I think my first pass workup is going to be.
Mhm. So in this case, would you be sending it?
I think it would be a good idea to send. If I have like a big liver abscess, I'm not sending it for that. I'm going to biopsy the liver abscess.
Right. Okay. So you're sending it in part because you're not sure that it's going to be feasible to go where the tissue is, and you might need to find the diagnosis through another pathway.
Yes. And then another thing you could consider is asking POLM if they think like a biopsy of the lung lesion or bronchoscopy will be helpful.
Okay. As you predicted, there are a lot of tests. You ready? All right, fasten your seatbelt. Quantiferon Gold TB negative, HIV negative, RPR negative, MRSA negative, Hep B serology, non-immune, Hep C negative, Toxo, IgG, NM negative, Crypto negative. Just run through these, and are there ones that are definitive and ones where it doesn't tell you that much and it could still be this thing even though the test is negative?
Yeah, so I'll start with the Quant Gold. So that does not rule out tuberculosis. A fair proportion of patients with active tuberculosis will have negative Quant Gold testing. So I don't think it's that helpful, and it doesn't rule anything out. It is helpful to know that she's HIV negative, which brings us down to the Toxo. Like if was HIV positive, then Toxo would be a consideration, although less likely to have lung lesions in a patient with HIV.
Negative CRAG, rule out
CRAG.
Crypto?
A negative CRAG does make it less likely, although in an HIV negative patient, I think the sensitivity is lower, but I think makes it unlikely.
Okay. All right, that's your first list. Second list, histoplasma antigen negative, complement fixation negative, Coxy negative, Coxy ID, CF negative, MNGS, they did it too, pending. E histolytica negative, beta-D-glucan 48, galactomannan negative, blood cultures negative. Any comments on that list?
So our endemic fungal serologies are negative, which brings it down on my list a little bit, but also are not perfect sensitivity. So not a rule out test. And Amoeba histolytica I wasn't really thinking about, but it's reassuring that it's negative. And then
Is that on your list of pulmonary brain things?
not on mine.
No? Okay. Not on anybody else's? No, it's on nobody's. Okay, good.
And then negative galactomannan and beta-D-glucan make aspergillus less likely with a disseminated infection. Although in an immunocompetent patient, those are less sensitive, but also makes aspergillus again less likely. So
Okay.
and negative blood cultures makes endocarditis, which we had been talking about, less likely.
Okay, we have one more list: respiratory testing, AFP sputum negative, MTB PCR negative, fungal culture negative. All right. Anything you want to go through on that group?
Yeah, there's a pretty sizable lung consolidation. So I do think the AFB sputum cultures and TB PCR are somewhat reassuring, but you really need the cultures. And even then you can have culture negative TB. So it doesn't completely rule it out. And then negative fungal culture, sometimes we do grow like cocci on a fungal culture. So far nothing is pointing to TB, specifically fungal culture negative.
Okay. So
that makes those things less likely, but not completely ruled out.
yeah, I guess I'm struck by a lot of negatives here.
Yeah.
You are too. Okay. What do you do now?
So then I think I'd revisit the brain biopsy.
Okay. And is that the list of tests that you would have sent, or there anything missing that you would have looked for? Anything that was sent that you don't think they needed? Sounds like
I think it's a pretty good workup. I don't know that I would have sent the entamoeba.
okay. It's probably just a rounding error when you take the entire cost of the workup. And the metagenomic test you agree with.
Yeah, I think
from the get-go in a case like this.
We could also revisit actually directly biopsying that lung lesion as well.
Mm-hmm. Is that how you approach it? You probably talk to pulmonary and to neurosurgery and kind of decide we need tissue from somewhere and which one's the highest yield and lowest risk.
Mm-hmm.
Okay. They decided to biopsy the left temporal lesion. They found a macrophage-rich lesion with gliosis, non-specific, and can see at the edge of a lesion, including neoplasm or infection. No malignancy was seen. Rare mitosis seen, could be reactive. Correlation with all the negative microbiologic studies is suggested. Thank you. Biopsy sample sent for cultures, fungal, negative, AFB, negative, bacterial, negative, and UPCR sent the biopsy sample, negative.
Well, that's disappointing.
All right. What now?
I mean, it seems like with the macrophage-rich lesion with gliosis that they may have gotten the edge of the lesion and not actually the core where we would have the highest yield.
Yeah. So you're telling them to go back in?
Well, we haven't really talked about whether biopsy of the pulmonary lesion would be feasible. I might revisit that at this point or rebiopsy the brain again.
Okay. So here's a summary of what we think is here. A 68-year-old woman with a history of poorly controlled type 2 diabetes, recently immigrated to the US from Mexico, a month of headache, fever, cough, multifocal ring-enhancing brain lesions, and an acute pulmonary lobar consolidation. The workup has been unrevealing, and the metagenomic testing still is pending. And so it is your turn to have a final thought on the diagnosis. So a diagnostic test returned.
Well, I think at this point, the three main ones that I'm thinking about are TB, cocci, and nocardia. Our testing that we've done is negative for TB and cocci. Nocardia actually might grow on those sputum cultures, but can be hard to actually culture out. Patient kind of has some risk factors for all three with gardening for the nocardia, but isn't known to be immunocompromised, though she might be. I'm guessing that the positive test that comes back is that MNGS, because that's the only thing you haven't told me about.
That's true. And what do you think it showed?
So I'm going to say, given the negative tests for cocci and negative sputum evaluation, I would say nocardia.
Okay. And Ben, that would imply some sort of immunodeficiency that we have not uncovered yet.
I would be very worried about that if that's
okay. And there's no other test for nocardia other than the culture might grow, but sometimes doesn't. And you said, does it take a while? Is that what happens?
It can take a while.
Okay. So let us hear nocardia. Came back on the metagenomic testing. And so the final diagnosis is disseminated nocardiosis in the absence of known immunosuppression, but we will get a little bit more information about that. Why don't you reflect for a second, and then we've got a guest speaker to take us through some of the lessons of the case.
Well, I think that, these cases are really hard. This is something that we do come upon on the ID consult service not infrequently, especially with brain. We get a lot of unknown brain lesions. And it is particularly difficult because we didn't touch on this, but you're often making empirical treatment decisions. And with the differential being in so many different buckets, it's really hard to know where to focus.
Let me ask you about that. At any point along the way here, would you have started anything?
Yeah, I mean, I probably would have started treatment before the test came results.
For what?
I'd probably start with bacterial, because that's what's going to progress the most quickly and harm the patient.
Meaning once you've sent your blood cultures and all that other stuff is cooking, you would have started sort of broad spectrum antibiotics, or are you saying treat for nocardia?
So actually what I have done in the past is where there's a kind of an atypical seeming process with a brain abscess is sometimes I will start, instead of the typical Vinc ceftriaxone flagyl that we do for a bacterial brain abscess, I'll do linezolid and meropenem, because linezolid has great gram-positive coverage and CNS penetration, but it also covers nocardia really well. Meropenem has good gram-negative and anaerobic coverage, but also covers a lot, but not all nocardia species.
Right. And you think you would have done that here? You would have started?
I think with that lung CT, I would have.
Yeah, but not TB coverage and not fungal coverage, that you would have been confident enough that it's not that, and or they're going to be more indolent?
I think I would have waited for the TB sputa to come back. And for Coxie, I often will wait a little bit to get some diagnostic tests back, but sometimes if the patient's really sick, I'll start sooner.
Right.
It's really hard when you have to start Coxie treatment and TB treatment because the meds interact with each other.
Got it. And are you, as you're starting this stuff, are you worried at all about making cultures negative if you do the biopsy or any of that interaction between treatment and diagnosis?
Yes, I worry about that particularly with bacterial processes. So that is something that occurs. You sterilize your cultures and the patient is getting better. That's still helpful.
Great. All right, we will bring you back up at the end to have a few final comments, but Sophie Luce is here. She's a first-year ID fellow in the clinician educator track here in our fellowship program. She completed her MD at WashU in St. Louis, her PhD in molecular biology at UCLA. She was a resident and chief resident medicine at WashU. We were lucky enough to recruit her to our fellowship this year. So thank you for talking about this.
Thank you. All right, it's my pleasure to go through some of the high yield teaching points about this case, a lot of which Rachel already kind of expertly talked us through. So a little bit about nocardia from a microbiologic standpoint, some of the buzzwords that you'll hear. This is a gram-positive, partially acid-fast bacteria, and it grows, as you can kind of see in the photo on the right, as in these filamented branching rods. There are actually over 80 species of nocardia, and each species has different kind of virulence factors as well as susceptibility profiles. When we think about the epidemiology, Rachel already mentioned that this is an environmental organism. We see it in the soil, water, as well as in decaying vegetation. And transmission is predominantly via inhalation from the environment. Less commonly, we'll see it through penetrating cutaneous injuries, and even less common than that, rare reports of nosocomial infections or even ingestion-related infections. With respect to host risk factors, as Rachel mentioned, we predominantly see nocardia infections in immunocompromised patients, especially those with T-cell dysfunction. So that includes our solid organ transplant patients, stem cell transplant patients, persons living with HIV with CD4 counts, as well as patients on chronic steroids. We do sometimes see nocardia in patients with chronic underlying lung disease as well, including bronchiectasis patients. And as Rachel mentioned, something that's coming up in the literature is this association with an adult onset immunodeficiency related to anti-granulocyte macrophage colony stimulating factor autoantibodies. And so as Rachel mentioned, a lot of times in ID, if we see an infection that really should be in an immunocompromised host presenting in someone who has no known immunosuppression, we do recommend an immunodeficiency workup and even an immunology consult. And so in this particular case, this patient did have positive autoantibodies to GM-CSF. So this was likely her sort of occult risk factor for nocardia infection. As far as the clinical presentation, as already mentioned, the lungs are the primary site of infection. So patients can present with a variety of symptoms, including shortness of breath, cough, hemoptysis, fevers, and radiographically, this can present with nodules, even necrotic or cavitary consolidations. And as Rachel mentioned, sort of the second site that nocardia likes to go is the CNS, where it can present with either single or multiple brain abscesses. Less commonly, we'll see nocardia as a cutaneous infection. It can be a primary site of infection, like I mentioned, from some kind of penetrating cutaneous injury, leading to ulcers or even subcutaneous abscesses. We can sometimes see it spread along lymphatics, leading to this kind of sporotrichoid spread, and then rarely can disseminate to the skin via hematogenic spread. And last category, a clinical presentation, is disseminated nocardia, and this is defined as nocardia affecting at least 2 sites of the body. The lungs and the brain would be most common, then the skin, and then some rarer sites of nocardia infection include the eyes, the adrenal glands, knees, and even bone and joint involvement. We don't often pick nocardia up in blood cultures, but it can sometimes be associated with central line infections. And so just to kind of drive the point home, really want you to remember that nocardia can be this lung-brain syndrome. So if you see a lesion in the lung and in the brain in the right host, think of nocardia. And that is what is kind of highlighted on this next slide, and what Rachel talked about as well, is we like to think about sort of a syndromic approach in infectious disease. And here I'm just showing a slide from one of the ID podcasts, the Febrile podcast, thinking about sort of big buckets of infections that can lead to lung-brain syndromes. And in the bacterial bucket, nocardia is sort of number 1 on this list. When we think about diagnosis and treatment of nocardia, from a diagnosis standpoint, ideally, we're making this by culture of affected tissue. And nocardia can be difficult to grow. You might have to work with your microlab to hold your culture longer, or even maybe request some special media. And then from a treatment standpoint, this really is nuanced and depends on the severity of the infection, the susceptibility profile once we get culture data and the susceptibility testing back, as well as the patient's response to the drugs. And so on the bottom left, I'm showing a table just to suggest that if you have a patient with kind of stable lung disease, you may be able to use monotherapy, 1 single antibiotic like Bactrim. But a lot of these more complicated patients with critical illness with lung involvement, or even CNS infections or disseminated infections, we are frequently reaching for multiple antibiotics and using a combination therapy approach. Often with Bactrim and imipenem, but sometimes also including amikacin or other antibiotics like Rachel mentioned, including linezolid. And when we think about the treatment duration, this is a long treatment duration on the order of months, and can be, patient specific, but just sort of broad based. If we have just a skin infection, that might be on the order of 3 months, lung maybe 6 months, and CNS or disseminated pushing towards 12 months. But of course, this depends on the patient's response to therapy as well. And lastly, I just wanted to touch on metagenomic next generation sequencing, as this was how the diagnosis was made in this patient's case. As Rachel mentioned, this is an unbiased molecular diagnostic. It basically sequences all of the microbial DNA or RNA fragments in a sample, and we can run this on both CSF and plasma. As far as the clinical utility, there are kind of 4 main clinical syndromes that we have data for. So that would be an immunocompromised patient with a lung nodule or pneumonia, hematologic malignancy with febrile neutropenia, culture negative endocarditis, or patients who are critically ill with sepsis. But as you saw in this case, we will also reach for next-gen sequencing when we have a very high clinical suspicion for an infection, but other diagnostics, sort of classic diagnostics, have not been fruitful. As far as the interpretation of next-gen sequencing, it can be challenging. Some of the challenges with specificity include that we can pick up biologically present nucleic acids from microbes of unclear clinical significance. So often this requires working with us on the ID consult service to interpret the results. As far as the sensitivity, it is a very sensitive test and it is generally thought to have good negative predictive value. From a logistics standpoint, this was previously, from a plasma standpoint, a send-out test. We now run it in-house here at UCSF and has a very fast turnaround time. So as Rachel mentioned, on the order of a couple of days, we are getting back our plasma next-gen sequencing. A little bit longer for the CSF. I think it's run only once a week for CSF samples. And that's it. That's all my teaching points.
So we'll give you a little, first, any idea how much it costs?
$1,000 over to so to them in-house it's supposed to be
$4,000. I was wondering, why don't we just send it on to everybody? That's a pretty good reason. So $4,000 if you send it out, and maybe a little cheaper if we're doing it ourselves.
if they do the sample run it at the same time.
Uh-huh. Closer to a week of turnaround. Okay, thanks, Monica.
The value like is not well established. I wouldn't say that.
Okay, so I'm not sure if everybody gets negative predicted value, not quite as super well established, $4,000, and turnaround is not, it can be as long as a week here. Okay, we have some concluding, I'm sure people want to know what happened to the patient. And so a patient was started on antibiotics, and you see imipenem and Bactrim. 8 weeks later, imaging of both brain and chest showed substantial improvement. Unfortunately, she developed side effects on Bactrim, was switched to linezolid, stopped after 3 months due to cytopenias. Found, as we said, to have these anti-G-CSF antibodies on immunologic workup, given limited options to treat her infection, as well as radiographic and symptomatic improvement. Right now, she's being monitored off antimicrobial therapy, so we'll only have received about 3-ish months, despite the goal had been 6 to 12 months of antimicrobial therapy. So Rachel, why don't you come back up and see if you have any final reflections on the case, and thought you did a spectacular job. It does not, what do I know, but it doesn't seem like that easy a case.
Thank you. I mean, I think one thing that is striking about this case is that, you know, she's presenting as an immunocompetent patient, but she's actually not. So it's very helpful whenever we see a patient, we think about, you know, their susceptibility to infection, what type of infections they're going to be susceptible to, but keeping in mind that we don't always know is important, and keeping even in a seemingly immunocompetent in mind for an immunocompetent patient, a broad differential and considering more unusual infections.
If there's anything that can be done about the immunodeficiency, like how would that be treated?
I don't know.
Anybody know? No, well, you have a head shaking among our ID crowd here. So I don't know whether the patient just remains susceptible and you just have to pay attention to that. There's some treatment for it.
Yeah, I actually don't. The only thing I know about this is that it increases the susceptibility to nocardia because it's being written about more.
Dr. Dornberg said that.
Okay. Dr. Dornberg says rituximab can help with autoantibodies, so that would be
Makes sense.
considered. All right. Any other reflections?
And then also there was sampling error in this case, I think, with the path showing gliosis. So like being tenacious about getting a diagnosis, because if we didn't have this MNGS, we wouldn't know how to treat this patient. Have done as well.
Yeah. Interesting that you wonder whether they'd have to go back in again and try another sample. Let me just do a quick thank you, and then we'll open it up for 5-7 minutes of questions. So thank you, first of all, Rachel. That was really absolutely wonderful. Sophie, thank you. Terrific job. And also a lot of thanks to Ella, who is off at a medical appointment, but is the one who put this case together, and I think did it beautifully. It's a complex case. So with that, we will take a few minutes for questions or comments. Brian?
I did have one question. Do we know that it was sampling error, or I imagine this patient did get antibiotics for quite a while before they went into the OR, and so therefore was it actually just partially treated, and so it wasn't seen?
When do you come up?
And I guess the only other comment I'd make is that, and you mentioned it early on, Rachel, was that with the reduced diffusion on the MRI really does kind of, I think, suggest more of a pyogenic process. And I think some of the fungi or TB are less likely to show that on that kind of finding.
I don't think we got the timing of the biopsy here.
Biopsy versus antibiotics, but it's a good point that if it was a week after
Yeah.
antibiotics were started, that's possible. And in terms of, does nocardia cause more of a pyogenic appearance?
It does,
Bacteria?
yeah. Although sometimes like it looks kind of funny.
Some guys
Yeah.
didn't look like that. All right. Harry.
I've got an arcane pathophysiology question relating to the GM-CSF antibodies. So I think they're most famously known with the association of adult alveolar proteinosis. And we occasionally see those patients who come in for literally pulmonary lavage and washouts on the medical service, and those patients are prone to nocardia. But this woman, radiographically at least, and clinically, did not appear to have alveolar proteinosis. So I'm just wondering, is she truly immunocompromised because she hasn't exhibited any other infectious disease risk, or is the association with nocardia mostly because of the sludge in the lung and the surfactant buildup providing, a rich environment for nocardia to get started there, and it occasionally winds up in the brain?
I believe it's actually thought to be like a separate process. There was actually just a review article in CID 2 weeks ago about nocardia that mentioned this. And I believe they mentioned that it's thought to be like specifically the GM-CSF autoantibody, even in the absence of PAP, although PAP has long been known to be a risk factor for nocardia.
And Harry, do you know the relationship between this antibody and alveolar proteinosis? Like what's going on?
I think the idea is you inhibit pulmonary macrophages from doing their job of reabsorbing surfactant.
Interesting. Great. Any final questions or comments? Yeah, go ahead.
There was an interesting one in the chat from Dr. Jones. She was wondering, we were talking about the $4,000 for the next gen sequencing, but how much did it cost to send all of those other tests initially? And sort of playing devil's advocate, like why send anything else? Why not start with this? What do you think?
I think we're still getting to know the like real world sensitivity and specificity of MNGS, and we've had plenty of patients that we make diagnoses in other ways that have negative MNGS. So I think of it as an adjunctive test. Thus far, like I don't know the scenarios in which you would use it instead of other tests.
Do you think 10 years from now we'll just be sending a single blood test that's going to be analyzed some fancy way and we'll be done with it?
I'm skeptical.
You're skeptical.
I'm skeptical.
When you don't need to, we all fly to work.
Yes, right. All right, I think we're at time. Thank you. Thank you all. It was terrific.